Alaikum. Thank you very much for the very kind invitation. I'm going to talk about the updated APLAR recommendations on care for patients with rheumatic diseases during the COVID-19 pandemic. Before we move on, a little bit about the background. Well, the APLAR, those who don't know, it's an organization which caters with all the local societies working in Asia for rheumatology, and around more than 20 societies are working for APLAR. And the APLAR organization sent an urgent statement for the patients with the rheumatic disease during the COVID-19 pandemic. And however, we all know that this statement was presented in May 2020, but it had a lot of lack of evidence. And so this was the background. So APLAR called multiple authors and multiple rheumatologists from different countries within Asia. And I was lucky enough to be part of the authors of these recommendations. And myself, and along with my colleague, Dr. Sabah Samreen from Fauji Foundation Hospital, we were both the authors of these recommendations. So there were many other authors from different countries as well. So we had 22 members, which included rheumatologists, pulmonologists, infectious disease specialists, and a patient representative as well. So we had our first virtual meeting, which was held on 10th October 2020. And we had a plan to make the recommendations for the management of rheumatic disease patient during the COVID-19. And these recommendations were based on two tools. One was the grading system. And those who don't know what is grading system, it is a method for appraising studies to be included in guidelines or recommendations. Basically, it is a software, and in which what we do is that we put the studies into this system, into the software, and the software at the end of the day calculates if the study is a high ranking study or either it is a low ranking study. For example, it grades a randomized controlled trial as a high ranking study and an observational studies as a low ranking studies, and it downgrades certain studies on the basis of the risk of bias, inconsistency, indirectness of evidence, imprecision, and publication bias. I won't go into the detail of the grading, but this is how we grade an article. And where the grading system fails and we do not have enough evidence, we use the level of expertise, and we use the approach of modified Delphi approach, which has the 5 parameters based on the Likert scale, which means that 1 means the accept completely and reject means number 5 means the reject completely. So our aim was to review all the available new and pertinent evidence related to COVID-19 and background of rheumatic disease, to update our preliminary statement by developing consensus recommendation for the management of patients with rheumatic disease during the COVID-19 pandemic. This document has 24 consensus statements, 8 expert opinions, because we had certain paucity of the supporting evidence. So we had to go for certain expert opinions as well. And this document will definitely help in practical guidance in making the clinical decisions. But having said so, they do not include the recommendations on the specific management of COVID-19. So if somebody has questions related to the specific management of COVID-19, I'm not the very right person. But however, I'm happy to answer all the questions related to rheumatic disease management and background of COVID-19. We did a literature survey by using the Archives of Medicine, Medline, and PubMed and Meshwork. These were the keywords which we used to search all the research, including the keywords were NSAIDs, glucocorticoids, conventional synthetic DMARDs, biological and targeted synthetic DMARDs. We retrieved the data from the randomized controlled trials, non-controlled trials, cohort studies, comparative studies, case series, case reports. Abstracts were also reviewed, and expert opinions coming from different areas, we also reviewed that. So before I move on to the recommendations, I would like to ask the audience that what is the risk of COVID-19 in rheumatic disease patients? So how many of you think that the risk is increased in all the patients who have underlying rheumatic disease patient? How many of you think that the risk is decreased as they are mostly on hydroxychloroquine? The risk may be increased in some patients, and risk may be decreased in some patients. So we do not have a voting system, but make up your mind and think what is going to be the answer. Well, after having all the research publications, we made the recommendation that patients with immune-mediated rheumatic disease may be at a higher risk of symptomatic COVID-19 and of severe COVID-19 than the general population. So we found that there was a slightly higher risk of symptomatic COVID-19 in patients who had underlying rheumatic disease. So now the question is, who are these specific group of patients who have a slightly higher risk than the patients who do not have a rheumatic disease? So the question I would like to ask the audience is, those who are taking steroids, the lupus patients, rheumatoid patients, or the psoriatic arthritis patients? Make up your mind and think what could be the patient, what patients can be at higher risk. Well, so far the data which we found was that those patients are potentially at a higher risk, which includes the patients on glucocorticoids or taking 10 milligrams per day. But definitely additional factors which also play an important role in non-rheumatic disease, for example, the presence of comorbidities, older age, obesity, smoking also play an important role as a risk factor for poor outcome in patients with COVID-19. This is the list, a huge list. I won't go into the detail. The list has been proposed by the CDC, that these are the patients who are at slightly more risk of acquiring the COVID-19. So we recommend that the patients with the rheumatic disease should be strongly advised to follow all the preventive measures as stipulated by the healthcare authorities in their countries, as for patients without rheumatic disease. So the next question from the audience is there a difference in the outcome between the rheumatic disease patients versus the non-rheumatic disease patients? So how many of you think that both have the same outcome? How many of you think that rheumatic disease patients have a better outcome? Rheumatic disease patients have more chances to get cytokine storm, and rheumatic disease patients have a higher risk of respiratory failure and mechanical ventilation. I'm giving a couple of seconds. You can think on it. Well, the answer to this is not very clear, but multiple studies coming from Massachusetts Hospital and from China, from Wuhan, that there is a higher risk of respiratory failure and there is a higher risk of mechanical ventilation has been seen in patients who had underlying rheumatic disease. So the point is, should the diagnostic strategy for the COVID-19 in patients with the rheumatic disease versus the non-rheumatic disease be different? Well, there is no evidence to support a different diagnostic strategy. So whatever the diagnostic test you are doing for the COVID-19 in patients with a non-rheumatic disease, you just do the same for the patients who have underlying rheumatic disease. But having said so, now we know there is a lot of data coming up for the patients who they may develop more respiratory symptoms. So keeping this in mind, we recommend that the patients with the rheumatic disease should be tested as soon as they develop any symptom of COVID-19 because of the potential increased risk of poor outcome. Now I'm going to talk about the patients of management of rheumatic disease patients without COVID-19. So in the absence of contrary evidence, patients with a newly diagnosed rheumatic disease without COVID-19 should be treated as per the standard of care during the pandemic. So you need to know, you don't have to change your practice, but keeping this in mind, we have definitely some concerns about these three agents, which are rituximab, cyclophosphamide, and sulfasalazine. And a lot of studies have shown that they may have a role in altering the immune response to infection. And certain studies have also reported the risk of COVID-19 related deaths with rituximab, sulfasalazine, and cyclophosphamide. However, the true risk of infection associated with these agents under having an underlying rheumatic disease is still uncertain. So we were very much confused. Should we stop these medicines or should we? So we passed the statement that therapeutic options alternative to rituximab, sulfasalazine, and cyclophosphamide may be considered on a case-by-case basis. So, but this does not mean that you are not supposed to write these medicines. The management of acute critical conditions such as vasculitis, myositis, lupus erythematosus, these established therapies may be more beneficial than the alternatives. So the urgency to control the disease has to be prioritized over the potential risk of acquiring COVID infection. So if a patient you have come to you with the lupus erythematosus and you know that the patient needs cyclophosphamide, don't think that the patient is going to acquire COVID. So go and give the cyclophosphamide. Now, the next is the patient's management. Rheumatic disease patients has close contacts with COVID-19 infection. For knowing this, we need to know what is a close contact. So how many of you think that close contact is defined as within 3 feet for 30 minutes? Individual within 6 feet for 15 minutes or more? Individual within 6 feet for 10 minutes? An individual within 3 feet for 5 minutes. So you need to know what is a close contact. So I'm giving you a couple of seconds, sorry. Well, the answer to this is number 2. As per CDC, a close contact is defined as within 6 feet of an infected person for a cumulative total of 15 minutes or more over a 24 period. So we recommend that for patients with rheumatic disease who do not have COVID-19 symptoms and do not have a documented COVID-19, but have had a close contact with a highly suspected or documented COVID-19 case, the recommendations for rheumatic disease medications varies depending on the risk. So if you feel that the patient, your rheumatic disease patient has a very high disease activity, so just treat the disease activity. If you feel that the patient is in remission and he has contracted a COVID-19, you may stop. So it all depends upon the risk and the clinician's plan. So for asymptomatic rheumatic disease patients without documented infections, and if you plan to stop the medicine, if stopped after exposure, may be resumed once the test is negative. So the strategy is that if the patient is in remission, the disease activity of the rheumatic disease is well controlled, and you plan to stop the medicine, the plan can be, there can be 2 ways. Either you stop the medicine and ask the patient to get your PCR test done, and if it comes out to be negative, you can resume the rheumatic disease medications. The other way is in certain countries, for example, in Germany, they do not allow the frequent testing for the patient who are in contact without any symptom. So in that case, you can ask the patient to wait for 2 weeks of symptom-free observation from the day of exposure. So we recommend that if you plan to stop it, it can be resumed once the test is negative, or approximately 2 weeks of symptom-free observation from the day of exposure. This is based on, for example, in European, EULAR recommends testing even if the patient does not have a COVID-19 symptom, while German Society of Rheumatology advises this only for the symptomatic persons. So based on multiple societies, we have made this recommendation. Having said so, however, anti-malarials and NSAIDs may be continued, keeping in mind no matter the patient has been exposed or not. When we talk about steroids, all the other societies, including ACR, EULAR, they all recommend that steroids should not be stopped abruptly. You may try to wean off if the disease activity allows you to. The next question from the audience is, we all know that during this pandemic, our patients of rheumatic disease have suffered because of the non-adherence, because of many other reasons. So how many of you think that the rate of non-adherence would be around 0.1%, 1%, 2%, or more than 2%? Well, it's an easy answer. Well, multiple studies have shown that the rates of non-adherence is around 2.2 to 15%. And there have been many reasons have been postulated, like lack of availability of medications. We all know that hydroxychloroquine was unavailable and still unavailable in most of the areas. Inability to travel to the dispensing facilities, fear of contracting COVID-19, perception of worsening rheumatic disease activity, fear of immunosuppression. So we recommend that rheumatologists should explore the perceptions of patients and address their concern to ensure treatment adherence during the COVID-19 pandemic. Coming to the role of telemedicine, how many of you think that it works almost as good as physical examination in detecting disease activity? How many of you think that patients have deteriorated due to telemedicine? And how many of you think that telemedicine has failed to reduce the risk of spread of COVID-19 infection? Couple of seconds, make up your mind. I know some people would say that physical examination is always a preference, and it is more good and more reliable, but we need to go as per the evidence, and the evidence from multiple studies have shown that disease activity assessment through telemedicine is accurate, and the telemedicine definitely reduces the risk of infection during pandemic. So based on this, we recommend that the use of telemedicine should be strongly encouraged, especially in areas of high community transmission levels for follow-up of appropriate patients with rheumatic disease, if implementing such intervention is feasible and accepted by the patients. Well, this is a very hot topic of vaccination. And when I'm going to talk about the two aspects of, one is the general aspects of general vaccination protocols to be given during the pandemic for all the rheumatic disease patients. And I'll briefly talk about the COVID-19 vaccination. Well, we recommend that all the patients, no matter they have a normal or altered immunocompetence, should receive vaccination. I'm not talking about the COVID-19 vaccination here. I'm talking about all the other vaccinations other than the live vaccination. We all know that the live vaccination should be avoided in patients who are on immunosuppressants. And all patients should receive the vaccination based on the current country, regional or international guidelines. Immunization schedules of the patients with rheumatic disease should be maintained while adhering strictly to the safety protocols of COVID-19 prevention. Well, moving on to the COVID-19 vaccination. This is a recent draft, basically came from American College of Rheumatology, published almost 2 to 3 weeks ago on 8th February 2021. And briefly, I won't go into the detail of this. It says that all the patients should be prioritized for vaccination, and unless there is any contraindication to the COVID-19 vaccination, which is usually there is none. And they should receive the second dose of the same vaccine. And there is a debate still going on, and maybe these recommendations change. But so far, the recommendations by the ACR is that withhold methotrexate and cyclophosphamide at least 1 week before the vaccination. And for the rituximab, the vaccination has to be done 4 weeks prior to the dose of rituximab. But having said so, this all applies if their disease activity allows. Now, a lot of patients are coming to us with symptoms of myalgias, arthralgias, and rheumatic disease manifestations after the COVID. So we have seen that some of the laboratory parameters may become positive, which includes anti-nuclear antibodies, antiphospholipid antibodies, and lupus anticoagulant. But we definitely need a long-term follow-up because so far we could not find the actual link between the COVID-19 and lupus or antiphospholipid syndrome. So they have transiently became positive, and later on in certain studies they became negative. So we really don't know, does the COVID has an impact on making is a part of pathogenesis of the autoimmune disease or not. Similarly, many other clinical manifestations mimic rheumatic disease, for example, cytokine release syndrome, arthralgias, post-COVID and post-COVID myalgias, myositis, COVID toes, like pseudochilblains, and various rashes like livedo reticularis, macular rashes, stroke in young, Kawasaki, and GB syndrome, etc. So the next question from the audience is, the clinical presentation, is it different in rheumatic disease versus the non-rheumatic disease? So how many of you think that rheumatic disease patients mostly have a diarrhea at the presentation? Rheumatic disease patients have higher fever spikes as compared to the non-rheumatic disease patients. Rheumatic disease patients have a prolonged loss of taste. Rheumatic disease patients have a similar presentation as of non-rheumatic disease patients. You think and make up your mind. Well, so far what we found was that the clinical presentation is quite similar to that in patients without rheumatic disease. But having said though, this is the recommendation, but having said so, certain data is coming up that laboratory parameters were also found to be similar, except a higher white blood cell count at the presentation and the lower peak ferritin levels in rheumatic disease. These were the studies have been published in Clinical Rheumatology and Annals of Rheumatic Disease back in 2020. Now, your patient has COVID-19 in background of rheumatic disease. How to manage? Well, we recommend that hydroxychloroquine, NSAIDs, ACE inhibitors, and ARBs may be continued but should be individualized based on disease condition. The clinician should consider stopping or withholding DMARDs, targeted DMARDs, and biologics on case-to-case series. Hydroxychloroquine can be continued. Rheumatic disease patients with COVID-19 should be treated according to the standard of care. Corticosteroids should be used at the lowest possible dose, but do not stop abruptly. Immunosuppressants other than hydroxychloroquine, like azathioprine, cyclophosphamide, cyclosporin, mycophenolate, tacrolimus, should be discontinued in patients with COVID-19. Now the question is when to restart the treatment. Your patient has become positive, now he's fine. He asks you, when should I start the treatment? Now the question is that after 2 weeks from the recovery, after 1 month from the recovery, after 2 weeks from the onset of symptoms. Well, as per the data, we found that for symptomatics, in general, the rheumatic disease treatments may be reintroduced at least 2 weeks after the recovery of the acute COVID-19. Here, the recovery means the last symptom. For example, if the patient has developed COVID-19 on 1st February, for example, and the last symptom was 5th February, and you need to resume the treatment, then add 2 weeks after the date 5. That is after 19th February, she may start the treatment for rheumatic disease. For the asymptomatic patients, you may reintroduce approximately 10 days after the diagnosis of COVID-19. Do we have to go for the retesting? Well, so far there is no as such recommendation for the retesting. As per the CDC doesn't recommend retesting for at least 3 months in a patient with non-rheumatic disease. However, CDC has documented that they may be considered retesting for severely immunocompromised individuals. Coming to the impact of COVID-19 on quality of life, well, we all know that COVID infection has a negative impact on the quality of life, both a mental component and physical component. Similarly, social isolation and shielding has a negative impact on the quality of life as well. So these were the recommendations. This document must be having a lot of limitations. Most of the data, the most important limitation was that most of the data from the publication summarized here was coming from low to moderate quality of evidence. But having said so, this document, we have updated the recommendation, highlighted the potential risks of rheumatic disease patients, clinical manifestations of COVID-19. We have tried our level best to guide the principles and recommendations, highlighted the role of telemedicine, emphasized on the treatment adherence, and we have emphasized that there is definitely there is a change of quality of life during the pandemic. Thank you very much.